Welcome, everybody. We're so excited to have you on the Deprescribing show today. We have a really exciting episode about Let's Talk Sodium. And we're not talking about just salting your food. So we'll hit the reel and we'll be right back. All right, Donna. So, start of the show, Donna is here. She's been doing a ton of fun cases that she's been doing, individual patient reviews, which I think is just awesome to hear for the profession and how she's pushing it forward. But today we're talking about an interesting part of patient reviews, Donna, and monitoring sodium and some of the problems with not doing so. Passing it to you.
Yeah. So I really want to jump into a case, and I think it's a great idea that we do a case of the week to kind of highlight some of these issues that we see. And when we're talking about sodium, there's so many issues that we have with sodium. And there are medications that, of course, cause hyponatremia. And I really want to bring you through this really compelling case of this 90-year-old female who ended up in the hospital twice because of a medicine that was started and caused hyponatremia. So when you're looking at these medicines here, these are the medicines that she came in on. And as you're going through, you might be going, okay, whatever. Not certain where you're at with this, but now I'm going to tell you that she just started citalopram 6 weeks ago. Does that make a difference for you now? And that she was in the hospital at 3 weeks and then again at 6 weeks because of hyponatremia. When we look at a 90-year-old starting on citalopram, you got to start thinking slow and low, right? Like with many medications. So to
Yes.
start off at citalopram 10 milligrams might not seem like a big deal, but for a 90-year-old, it is a big deal. So really it should have probably started off at about 5 milligrams, but even without that happening, at 10 milligrams of citalopram, we can really cause some damage in regards to hyponatremia. So citalopram ends up being one of the highest SSRIs to cause hyponatremia. So it's most common with citalopram out of all of the SSRIs. So again, we have to be careful about what we're choosing for our older adults. The second part of citalopram that you need to be thinking about too, we've talked about this in some other segments, but it is the QTC prolongation too that can occur. And that's why citalopram is maxed out for older adults at 20 milligrams as a maximum. So instead of the 40 milligrams like it is for your regular aged adult, shall we say, a non-older adult. So when we're looking at these amounts, you can see how little bit of a narrow therapeutic range we have for citalopram with our older adults. So 10 milligrams, 20 milligrams, that's all you got to work with. So we have to be really careful and low and slow with these. So what happened is I picked up this patient when she was in the hospital for the second time. And going through her case, we noticed that she had hyponatremia. And we went, oh, okay, very interesting. Could be citalopram that's causing this. Let's go take a look. And oh, look, she was just in 3 weeks ago as we're reading through this case. We're going, oh, wow, what happened 3 weeks ago, right? Well, guess what? What do you think it was? Hyponatremia. So the
Hmm.
first 3 weeks that she was on the citalopram, she experienced hyponatremia. She didn't have any hyponatremia prior to that. Her blood levels for sodium were pretty consistent. They were probably in the a little bit higher 130s. So she didn't have a lot of room to move to that hyponatremic um, level. So when we talk hyponatremic is less than 135 millimoles per liter. So there wasn't a lot of wiggle room for her in the first place. So starting her on that citalopram, seeing that she came in for hyponatremia, they ended up taking care of that hyponatremia, providing the saline necessary through IV, and ended up um, discharging her from the hospital.
So
So
they did
here we
fluid
go.
restriction.
Yeah.
So they did
Good.
fluid restriction and added sodium on board. But
Mhm.
What did they attribute it to during the first stint? Was it, does this patient have CHF or liver
Yeah.
cirrhosis or anything along those lines?
No, there was none of that. I think that they probably thought maybe some slight fluid overload if there was some edema. I don't remember that as being an issue. It was really, she was in for hyponatremia. That was the reason why she was in the hospital.
Okay.
Hyponatremia was the diagnosis.
Yeah.
So we really have to start thinking about, like, why? The whys, not just fix and go.
That's right.
So anyways, unfortunately, she came in a second time a few weeks later, hyponatremia again, and this time had fractured her jaw from the fall. So significant surgery was necessary, rehab, etc. So during that time, we're cautioning on the citalopram, saying, "Whoa, you know what? Hyponatremia. This is probably what's occurring. Is the citalopram is relatively new for her, causing hyponatremia." So, looking at this further, we really need to be thinking about SSRIs in our older adults. So, what we want to make certain that we're doing when initiating an SSRI, or really any antidepressant or any product that could possibly cause hyponatremia, we want to first low and then slow. But we got to check sodium levels, right? We need to have some blood work done. So as we're going through this, we can look at this a little bit further. So let's go to the next slide real quick, if you don't mind, Kevin. And so what happened, right? So citalopram caused the hyponatremia, but there's also another prescribing cascade. Remember that from way at the beginning of all of these segments that I've done. We want to be super careful of prescribing cascades, and we can see this happening. Amlodipine, 2.5 milligrams, and then, oh, look, furosemide ends up being added on. So we have to be thinking about what is the cause and effect
Mhm.
of situations, especially in our older adults. So when we see these electrolyte changes, when we see fluid changes, we really need to be looking at the medicines. So really, a simple blood test would have reduced the risk of falls in the first place. It would have found the low sodium prior to a hospitalization, more than likely, because at 2 weeks is when you should really be getting that sodium checked. And then there'd be a reduction or change in the med, or um, and then we wouldn't have had the second fall that occurred either. So even if the first fall occurred and we caught it then at the hospital, we should have reduced it then. So now we go on to a second fall, and there's more issue there. So we want to make certain that we are finding these things and sharing these ideas too. These are really important in causing decreased quality of life. We talk about the polypharmacy, we talk about frailty, and we talk about anticholinergic burden. This is all a part of what we're seeing here. So we want to make certain that we're looking at sodium levels and really thinking about hyponatremia in our older adults.
Yeah, I think
So
those
part of what we
those are salient
go
points,
ahead,
Fritz.
Kat. Mm, yeah.
I
So
think with those, the one thing I wanted to ask you is really zoning in on the meds that you're pointing out here. For me, amlodipine 2.5 usually doesn't raise a flag. Usually it's above 5 milligrams that I've typically
yeah,
seen, but that definitely could be a possibility. But for the audience, when it comes to citalopram, I know that all SSRIs are capable of causing hyponatremia in one way, shape, or form. Citalopram's shown some more evidence to be a higher likelihood. You mentioned, I think, a
mhm,
really fantastic pearl that I wanted to make sure everybody received was it's typically within the first 2 weeks of starting that you
yeah,
notice that significant change. So when it comes to monitoring a new start patient on an
mhm,
SSRI, what's your
yeah,
typical kind of window of monitoring sodium levels? Well, within that first
yeah.
month, are you looking at doing something every 2 weeks? What's the case, Donna?
Mm. Yeah, I would definitely check every 2 weeks. And you might want to do that a couple of times, because it's really in that 2 to 4 week range that we're really seeing the drop in sodium. But the other part is, if you increase the dose, then you also need to do another check within that 2 weeks of the increased dose too. So, and then if anyone comes into the hospital hyponatremic, you really got to be looking at those meds. That's going, okay, why? Why is this person? Or have they been sick? Was there diarrhea or vomiting, some type of virus that they have, or is there could be other things like fluid overload that could be causing a hyponatremic factor. Another thing that we see in type 2 diabetes folks is if their numbers go rather high, they're told to drink water, right? So they could be drinking water to try to lower that blood glucose level, but they're actually could be diluting their sodium. So that's another reason to be careful of with these what people are doing and trying to figure out what's happening with those sodium levels.
No, that makes a lot of sense, Donna. I know that, there's a few different things that can pop up with those sodium levels, like psychogenic polydipsia and SIADH and all of those kind of things that come along the lines. The ones that you see the most often, though, if you see someone you're surprised by them having hyponatremia, is it typically those SSRIs?
Yeah, we
Yeah.
see it a lot,
Okay.
unfortunately. And that's why I really wanted to highlight this particular case tonight too, because it is just such an important factor. And unfortunately, folks are living, and not unfortunately that they're living longer, but they might be experiencing depression because of the isolation and things such as that that have gone on, especially with COVID and not really getting back. We all have to kind of relearn to socialize again. So, and if you think about people who might not be driving or might have had a poor couple of years and have had such dramatic changes, that they're probably being prescribed these SSRIs. And it's not just SSRIs either, it's antidepressants. So tricyclic antidepressants and SNRIs, those can also cause sodium hyponatremia, but the SSRIs seem to be the ones that are most pronounced, shall we say,
Mhm.
with this particular side effect. So, and if you think about folks too who might have had cardiovascular events occur because of COVID, or even just chronic disease states, having heart failure issues and fluid overload because of an exacerbation of heart failure. These are all things that we need to be looking at the sodium levels for, but add on these other meds and we really need to be careful. It's not always just one thing, right? We know that there are these additive effects. So it could
Yeah.
be that they're at borderline with their SSRI on board and it might not be noticed, but then you change a little something and now they become hyponatremic. So sometimes it's looking at those numbers and making certain that, oh, you're really close to having a low. So we need to be looking at that a little bit closer.
I think that's perfect. I think the takeaway note before Don and I flip over to our PHLI and continue the conversation, hope you guys join us, is really when we're prescribing medications, the importance to prescribe monitoring or to combine the monitoring together when you're starting off is just paramount, for our
Yeah.
patients. I think it happens. There's a disconnect, Donna, that you and I can talk about at a later date between what happens between the prescriber's office and the dispensing location when it comes to
Mhm.
monitoring and all the parameters that are necessary to keep our patients safe. And I think we can do a better job of pulling all those things
Yeah.
together. But thank you guys for joining us on another exciting episode of this Deprescribing show. Let's talk sodium. If you want to talk more sodium, we'll see you in just a little bit.